Our next speaker graduated from the University of the Philippines College of Medicine and finished his urology residency at the UP-PGH, after which he completed 1 year of fellowship in minimally invasive urology at the University of California Irvine under the mentorship of pioneering endourologist Dr. Clayman. To date, he has published several works in the field of endourology and uro-technology in international peer-reviewed journals and currently serves as an expert reviewer for the Journal of Endourology. He is a diplomate of the Philippine Board of Urology, consultant urologist and assistant professor at the Salle University Medical Center, and active consultant at Medical Center Manila. Let us now welcome our next speaker, Dr. Raphael Benjamin B. Arada.
Hi, good afternoon, everyone. I'm Dr. Raphy Arada, and I'll be presenting on the topic of the latest technology in urology. First off, I would like to thank the PUA Mindanao chapter led by its president, Dr. Hipol, the rest of the officers of the distinguished organization, and to Dr. Firaza, the course director, for this very, very kind invitation. It is such an honor to be invited to speak to a group of highly distinguished urologists. And I am also glad to see that there are also many interested non-urologists who registered for this event. So welcome to you all. For my disclosures, I have no financial relationship with industry, and this presentation is not sponsored. However, I think it's pertinent to note that certain research works and trials on some devices which I will be presenting, wherein I was a co-investigator, have been sponsored or supported by their respective manufacturers. To begin, as urology is a specialty that deals with a very diverse patient population and treats a wide variety of disease conditions using different modalities, advancements in technology will always have an impact in the improvement of our field, to the point where some would actually argue that urology is increasingly becoming a technology-driven specialty. And as such, for the next half hour or so, I would be focusing my discussion on certain technology that are currently changing our field or would eventually significantly have a major impact on the way we do things. In the past century, the world has witnessed an exponential growth in technological advancements. And just in the past few decades, scientific breakthroughs and innovations are rapidly advancing at such pace that it's getting more and more difficult to keep up already. And one of the best examples to demonstrate this in the field of urology and in minimally invasive surgery is the development and use of surgical robots. Intuitive Surgical launched the Da Vinci S surgical robot in the market just 15 years ago in 2006, back then allowing surgeons, especially us urologists, to perform minimally invasive surgery with improved dexterity and surgical precision under 3D high-definition vision. And this model actually emerged as a simplified setup of the first generation prototype they released in 1999. And then just every few couple of years or so after that, we saw significant improvements in each of the subsequent models. In 2009, the SI was released with more advanced features, allowing dual console surgery, Tile Pro integration, and all that. And eventually, further advancements in vision and instrumentation. The SI model would then become so popular and widespread and used in a lot of centers worldwide, including hospitals here in the country that have adopted the use of robot-assisted surgery. And what's in the picture is actually the SIE, which is like the economic lower-cost version of the SI, wherein instead of having 4 arms, it only has 3, but it's still an SI. Then in 2014, even more advanced, the XI was released in the market. While the surgeon console for this model looks pretty much similar to the SI, the big change is really in the patient cart design, which they totally reinvented from the previous model. First, it allows for an automated setup mechanism, which allows for easier and more optimal docking. Also, it has an overhead instrument arm architecture that would allow anatomic access from practically any position, and with longer instrument shafts, smaller and thinner arms, and redesigned joints. And although also with four separate arms, the camera or the endoscope can be attached to any of the four arms, unlike the SI, which has one arm dedicated for the camera. And not to mention its camera, which was also upgraded to be a more compact and has improved clarity and visual definition. And these, together with other upgrades, allowed easier and optimal setup and now allows multi-quadrant operations with maximum mobility and flexibility of the system during surgery, under better vision and with more advanced instrumentation, opening up the possibilities of a wider range of surgical applications. And as advanced as the XI was, in 2018, an even newer model was released, the SP or the single port model, with a single robotic arm incorporated with smaller wristed instruments and an articulating camera, allowing entry and procedures done through only a single port. With all these advancements in surgical robots, urology is one of the disciplines that has greatly benefited the most from this technology, with a very wide range of applications to our field. In pelvic operations, such as radical prostatectomy and radical cystectomy, as well as renal procedures such as radical and partial nephrectomy, and also in reconstructive surgery such as pyeloplasty. Now, while Intuitive Surgical's Da Vinci has dominated or basically monopolized the market for surgical robots for the past 20 years, in 2019, a lot of their core patents for the technology have actually expired already, and this then allowed many possible competitors to enter the field. And among the new surgical robots developed recently is the Revo I from Korea, which, as you can see in the picture, is very, very similar in design to the Da Vinci, with the four-arm patient cart, a surgeon console, and the vision cart. But it comes at a much more affordable price, with good outcomes also shown in the recent human trials. CMR from the UK has also released their surgical system in 2019 with independent individual modular robotic arms mounted in portable carts. It comes with a lot of exciting features, among which is the ability for haptic feedback, and early data for its use are also likewise promising. Companies from Germany and Japan are also in the game, coming up with their robots that have already started to obtain approval and have likewise been shown to have good outcomes in early human trials. And a lot more of other companies from different countries all around the world are now on this robotic surgery race. And with these developments, it is expected that the use of robotics in the field of urology will definitely be more widespread in the next coming years or so. However, again, at present, despite its demonstrated benefits, the most important concern for adapting the use of surgical robots in urological surgery, probably more than any other available technology, is the cost, with the SI or the XI costing around at least $2 million, with additional expenses for maintenance and disposable equipment. And although the newer models promise greater affordability and accessibility, none would in the near future probably be down to costs that would approach simple laparoscopic surgery. And other issues being raised are with regards to training, specifically if current robotic surgery credentialing policies are adequate to ensure surgeon proficiency. And as still this is a relatively still new technology, there are still some arguments about safety concerns, although of course data over the past decade have demonstrated good patient safety outcomes already. But regardless of these concerns, it is already probably safe to say at this point that robotic surgery is here to stay and will definitely play a major part in the future of urologic surgery. Now, aside from robotic surgery, endourology is probably the field that deserves a more in-depth discussion when it comes to the topic of uro-technology. In fact, endourology is so closely linked to advancements in technology that what we used to know as the WCE, or the World Congress of Endourology, is now called the WCET, or the World Congress of Endourology and Uro-technology. And probably it is in the area of endoscopy and lithotripsy that has really been making the most of the technological advancements in the recent decade, as this field deals with a lot of new advancements in optics, high-energy devices, minimally invasive access, and imaging modalities, among others. there are a lot of potential technological innovations that we can explore and utilize. Flexible ureteroscopes have been around for quite some time and was actually all the way back in the 1980s when improvements in the scope into how we know it now were introduced, such as having a working channel within the scope and as well as allowing a mechanism for active deflection. And these have been standard features of the scope since then. And over the years, there have been some improvements in durability, miniaturization, deflection capability, and replacing fiber optics with digital imaging, eventually lowering the costs and expanding availability. But still, flexible ureteroscopy does have its limitations, as standard scopes can only typically be up to a certain diameter to be allowed safe entry into a narrow ureter or an access sheath. And with just a single working channel, limiting the simultaneous use of instruments and limiting irrigant flow capabilities. And of course, there are still limitations regarding its durability and cost, especially when we compare these to the rigid ureteroscopes. However, recent improvements in optics and materials are allowing flexible ureteroscopes to be cheaper and taking advantage of the advent of single-use disposable scopes allows for rapid prototyping of newer novel endoscopes. One example is the development of shorter length ureteroscopes. Standard flexible scopes are typically around 65 centimeters long, and by physics, the length combined by its narrow diameter would result in relatively low irrigant flow rates, especially when instruments are inserted through the same single working channel where the fluid passes through. And of course, irrigation is very important to us in terms of visibility and surgical efficiency. Now that manufacturers are no longer confined to the one-size-fits-all approach to developing these scopes, recently, as an example, Dornier developed a prototype for a shorter ureteroscope, which is female-specific. So it takes into account the shorter urethra in females, and the scope just has a working length of just 45 centimeters. So the premise of this is that it would not only require less material to produce, but could actually increase the irrigant flow rates during ureteroscopy. And we actually did a benchtop study on this, which we recently published in the Journal of Endourology. So here we found that although the 45 centimeter scope is the same in all aspects except for the length to the standard scope, we demonstrated that there was actually a significantly higher flow rate by an average of 11% more, with the highest increase noted when there's an end-gauge basket in the single working channel. And there were also noted no differences in deflection capabilities. And from this prototype, it's exciting to see how these differences would eventually translate to clinical utility. But really, even with modifications like this, the increase in flow rates would still be limited considering the fact that the same single channel we use for irrigation is also the same channel where we put instruments such as baskets, wires, and laser fibers. And also, having just a single channel in the scope makes flexible ureteroscopy using multiple instruments a bit less efficient when we have to remove one instrument like a laser fiber all the way through the length of the scope before we can insert another one, such as say a basket for stone extraction. And of course, the best way to go about this limitation is to figure out a way to put another channel into the scope itself. And that's exactly what Wolf did. So this is the Wolf Cobra. It is a flexible fiber optic ureteroscope which has two separate channels or lumens within it. So the first channel or lumen is designed as a traditional working channel. And there's a second channel which allows for simultaneous instrumentation or can be attached to a suction or even for just additional flow of irrigation fluid. And having two separate functional channels could allow for applications such as simultaneously using a basket to secure a stone on one channel, with the laser fiber on the other channel simultaneously performing laser lithotripsy. This can also be applied, for example, resecting an upper tract tumor, with an instrument on one channel maintaining traction on the mass, while the laser fiber on the other lumen performs the resection. Or we could have the second channel used exclusively for irrigation, which would provide increased flow and improved visibility during ureteroscopy. Now, earlier studies by the team of Dr. Monga way back in 2011 demonstrated that deflection and flow characteristics were superior when larger or multiple simultaneous instruments are used in the working channel of the dual lumen scope. Now, as far as its clinical implication, our team at UCI actually had the wonderful opportunity of performing a prospective randomized study to objectively assess the efficacy, safety, and ease of operation of a dual lumen scope compared to the traditional single lumen scope. The study is still ongoing currently, but preliminary results from our first 79 patients undergoing ureteroscopy for renal stones less than 2 centimeters revealed higher absolute stone-free rates with using the dual channel scope. And overall, the operative times were similar, but in cases requiring laser lithotripsy, the lacing time was significantly shorter, actually less than half, with using the dual lumen scope. And among the patients with pre and post-operative CT, the median rate of stone clearance was 7.1 cubic millimeters per minute for the dual lumen group compared to just 3.7 for the single channel. Our preliminary results also revealed actually that the dual lumen scope is subjectively better for surgeons in terms of visibility, comfort, ease of deflection, and overall ease of use compared to the single lumen ureteroscope. Soon we will be able to publish our findings once the trial is completed, but for now these definitely look like very promising results. But still, again, despite current and foreseeable future advancement in the scopes, its diameter will always be a major limiting factor, as ureteroscopes can only typically be up to a certain diameter to be allowed safe entry into a narrow ureter or ureteral access sheath. And as ureteral injury is a feared but quite frequent complication of access sheath insertion, as we would all know, surgeons would typically not go beyond the French 12 or 14 size sheath for ureteroscopy, as larger sizes would have a potentially higher chance of causing injury to the ureter. And with that in mind, the team of Dr. Clayman at the Department of Urology partnered with researchers from the Department of Engineering to develop a device that could accurately measure the amount of force exerted by deployment of the access sheath as it goes all the way up the lumen of the ureter. This is the UC Irvine ureteral force sensor device. It is a prototype model but is actually already being used clinically in the operating room and endoscopy suites. And it is a small handheld device. And how it works is that it has a force gauge at the tip, which attaches to the proximal end of the ureteral access sheath during deployment, with a guide wire passing through it, as shown in the photo. And then the device is then connected wirelessly via Bluetooth to a tablet, with an app showing in real time the amount of force being exerted by the sheath on the ureter. And based on initial porcine studies on the device, a threshold of 6 newtons was determined to be the safe threshold to avoid causing injury to the ureter. This force sensor would then allow the urologist to use a larger ureteral access sheath, knowing with confidence that it would still well be within safe limits and avoid causing injury to the ureter. This likewise makes it easier to pass the scope multiple times back and forth to remove more fragments of kidney stones in less time. And with this, we can go as high as, say, a French 16 outer sheath, or possibly even bigger than that. And if the sensor detects the force to be approaching 6 newtons, the safety threshold, then we can just stop and then shift to the next smaller caliber sheath until we can eventually use the largest possible sheath that would still be well within the safety limit. And in the first clinical trial on 200 patients at UCI, which was published recently at the Journal of Urology, a French 16 sheath was able to be deployed in 61% of the renal units with a mean peak force of 5.7 newtons. And although 2 high-grade ureteral injuries occurred, it is important to note that in both cases, more than 6 newtons of force was recorded at some point during insertion. And it was also noted that the severity of the ureteral injury, as determined by the pulse or post-ureteroscopic lesion scale grade, correlated directly with the peak insertion force. And now, with the possibility of deployment of larger access sheaths and the previously discussed advancements in flexible ureteroscope, comes the improvement and safety and efficiency of ureteroscopy and laser lithotripsy. But of course, the third and most important component to take into consideration for efficient laser lithotripsy is the lithotriptor itself. Since the 1990s, when Dr. Denseth first performed laser lithotripsy for urolithiasis, holmium YAG laser has pretty much been the gold standard modality for laser lithotripsy. And for the past 30 years, holmium YAG has been the ideal laser for us urologists due to its good water absorption, its proven safety and effectiveness in fragmenting any type of stone, and also having the ability to be used for soft tissue applications with very good hemostatic characteristics. And since then, there have likewise been some improvements in the technology through the years, with modifications in settings such as in pulse width and duration. And one of the notable recent innovations in holmium lithotripsy is the MOSES technology, wherein the laser settings are modulated so that for every pulse, there are actually two successive pulses fired very rapidly one after the other. The first one parting the water like Moses, and the second pulse going straight right through its paths, hitting the stone directly. And with this, they demonstrated benefits included reduced retropulsion, as well as more efficient stone ablation and shorter fragmentation times. But still, all of this is built around the holmium YAG laser lithotripsy technology, which by its design would still have its limitations. And now, the technology that is really making waves in the endourology world recently is a thulium fiber laser, and thus would probably require a more in-depth discussion. Thulium fiber laser, introduced fairly recently, is a totally new and exciting technology. For those who may not yet be familiar with this, before we discuss how it works and what it is, let's settle what it is not. So thulium fiber laser is not the same as thulium laser or thulium YAG laser that we all know. As urologists, we are familiar with thulium as the one we use for prostate enucleation and all that. But thulium fiber laser is a totally different technology. To fully understand and appreciate what's new and exciting about thulium fiber, let's compare it to how our typical holmium YAG lasers work. So these next series of simplified images are from a paper by Dr. Taxer, who has done really tremendous work on this topic. So traditionally, this is how our lasers work. Within a cavity, you have a YAG crystal embedded with holmium ions, and then light emitted from a lamp inside interacts with the ions, resulting in the emission of photons, and then radiation is reflected between the mirrors within the cavity, being amplified as they interact with the excited ions and stimulate emission of multiple additional photons. And then, a transient opening of the cavity releases the radiation in the form of a pulsed laser beam, which is then transmitted to a laser fiber or the patient fiber by means of a complex optical laser beam coupling system. And as a single cavity can typically go up to only as much as 30 watts, we would need several resonance chambers to achieve higher power and frequency levels. And by doing so, they generate much more heat, which would require big water cooling systems. And that's the reason why holmium laser machines are so big. Now, thulium fiber laser, on the other hand, works in a totally different way. Instead of having a laser cavity wherein radiation is generated and amplified from a lamp pump solid-state laser, thulium fiber laser, as the name implies, consists of very thin and long silica fiber which has been chemically doped with thulium ions, which are then excited by multiple laser diodes. So instead of having a cavity wherein the energy is amplified, the fiber itself is the amplifying medium. And then instead of having a complex optical system to transmit this to the patient fiber that goes into the ureteroscope, we can directly attach the patient fiber to the thulium fiber laser. And compared to the other system, this one is relatively simple and does not generate much heat, and would therefore not require large cooling systems to perform at higher power levels. And currently, thulium fiber laser is being used with significant advantages in lithotripsy, both for fragmentation and dusting settings. And also, it has soft tissue applications, such as in prostate enucleation and resection of urothelial tumors. Now, making a comparison between thulium fiber laser and holmium YAG, I will just touch on a few of the notable advantages, as discussing the full capabilities and specifications of thulium fiber laser would probably need a whole lecture by itself. So to compare with holmium YAG, first they allow for much thinner fibers than the ones we have for holmium, with core diameters as small as 50 microns, and with speeds that can go up to more than 2000 hertz, coupled with pulse energies that could go as low as 0.025 joules, and the ability for much higher pulse durations. This allows us to play with a wider range of settings, such as combining very low pulse energies with very high frequencies to achieve a certain level of power. And with this, it has been demonstrated that thulium fiber allows for a much faster stone ablation for either dusting or fragmenting for any stone type. And while both holmium and thulium fiber laser systems are capable of dusting stones, thulium fiber produces more quantity and better quality of the dust, meaning much smaller dust particles after lithotripsy, which could then be more easily evacuated. And lastly, thulium fiber produces significantly less or sometimes even non-existent retropulsion, which means it could be easier for surgeons, especially the trainees, to perform lithotripsy with these. And of course, as we previously mentioned, without the need for large water-based cooling systems, the machines for thulium fiber are reasonably small and can run on just simple air cooling mechanisms with a fan, and in turn makes them small enough to fit in your typical endoscopy cart, or for those who would prefer to take their machines with them to different hospitals or what have you. It can possibly be possible with this. And also, the machines are simple enough to be plugged in a standard power outlet without the need for any complicated electrical wiring, like anyone who tried to install a holmium laser in their center would be very well familiar with. And now as to the current state of thulium fiber laser machines currently available in the market and in clinical use. IPG Photonics was the first to gain approval for the clinical use of this, but it was first approved only in Russia and in India back then. And as such, they have gotten quite a head start with this technology and were able to produce the first clinical data for it. The other is the Olympus Soltive Super Pulse. Initially, until last year, in the US, this was just being used in the context of clinical trials in a few centers, with Ohio State being the first. But now, recently, it has gotten FDA approval already for clinical use. And so now, thulium fiber laser technology is making its way into more and more centers in the United States. And of course, soon, hopefully, the rest of the world. Now, as we have discussed the latest technological advancements in access, ureteroscopy, and laser lithotripsy, we now move towards finding the optimal technique for safe and efficient ureteroscopic laser lithotripsy. Putting it all together, we performed a study to demonstrate the optimal renal stone dusting technique, combining the dual lumen scope, the ureteral access sheath, and the thulium fiber laser, which we presented at the recent meeting of the AUA Western section last year. In an ex vivo study of 48 porcine kidney ureter models, divided into 8 groups according to laser type, the use of a dual lumen scope with suction, and the use of an access sheath, calcium oxalate stones were implanted into the kidneys and dusted with 8 different combinations of laser, scope, and the use of an access sheath. And then dusting was done at 16 watts for 20 minutes, and then the residual fragments were then assessed. Here we found that the greatest stone clearance of 94% was achieved with using the thulium fiber laser through a dual lumen scope with suction and using a ureteral access sheath. And the lowest stone clearance of 65% was achieved with a holmium laser through a single lumen scope and no ureteral access sheath use. Very interestingly, when used without either a suction or access sheath, there were no differences in stone clearance between thulium and holmium lasers. And thulium fiber had a greater stone clearance than holmium YAG when suction was applied in the absence of an access sheath. So with this, it was demonstrated that in terms of renal stone clearance with dusting, The advantages of thulium fiber over holmium were manifested when it was used in conjunction with a means of evacuating the stone fragments, such as concurrent suction to a dual-lumen scope and or a ureteral access sheath. Now, considering all these benefits of the thulium fiber laser, we now get to ask, is it the future and should it eventually replace the holmium YAG as the standard for laser lithotripsy? Now, with the data available, most probably that's where we're headed. But then again, this is still a fairly new technology, and although already approved with good clinical safety and efficacy results, large clinical trials are still currently ongoing for us to fully realize its capability and long-term safety profile. For example, things such as how about the heat generated by the energy on the kidney? While it's known to be generally safe, it's still interesting to study, and we actually did and published a recent study on this, where in an in vivo study, we noted that in the absence of a ureteral access sheath, high-power thulium fiber laser fragmentation settings may create temperatures of over 44 degrees that could potentially result in urothelial tissue injury. And take note that we were able to record these temperatures, these high temperatures, from the renal calyces themselves, as the temperature at the tip of the scope measured separately was actually noted to be up to 20 degrees lower than what's on the kidney itself. Now, it's just something to keep at the back of our minds when we're performing laser lithotripsy at high power fragmentation settings, and probably even strengthens the use of the ureteral access sheath when we do RIRS. But then, all things being considered, the near future looks very, very bright for the future of ureteroscopy and laser lithotripsy, especially with thulium fiber laser. And lastly, it is important to touch on the latest technology in terms of diagnostics in urology. And just as technology has changed the way we treat urological diseases, it has also greatly affected the way we diagnose and monitor them. Now, it was just in the late 80s to early 90s when the clinical utility of PSA as a tool for screening and monitoring prostate cancer was demonstrated. And now, recently, with the development and more widespread availability of the multi-parametric MRI, we are again seeing a possible shift in the way we diagnose and monitor prostate cancer. And in terms of treatment planning, as we are becoming more dependent on imaging modalities such as CT scan, when we plan for minimally invasive surgery for stones and tumors, a lot of exciting new development is also going on in this regard. One example is going a step further with 3D reconstructed CT images that is now being commonly adopted to turn these 3D CT renderings into either 3D printed models or, as is typically employed at UCI, viewed using immersive virtual reality, which we have been demonstrated to improve surgical planning. But before I get to the next part, let me just mention the difficulty with making these 3D models for immersive virtual reality. It is quite cumbersome and takes quite a lot of time reconstructing the renal parenchyma, the vessels, the collecting systems, all of these manually, slice by slice, from a non-contrast CT scan. And as opposed to high HU valued structures such as bones and stones, it would take manual effort to accurately delineate these anatomical structures from adjacent organs of similar density on a non-contrast scan. And now, an exciting development we have started to adapt for this purpose is the use of artificial intelligence to reconstruct the models automatically and with great accuracy. In partnership with the Center for Artificial Intelligence in Diagnostic Medicine at UCI, with a ton of existing kidney segmentations we have manually created previously, they started creating an algorithm that is able to generate these segmentations automatically. And comparing it with the ones done manually, we found very, very high concordance. Now, going to artificial intelligence, I'm not an expert in AI or programming at all, but I'll try to explain simply how it works. So, AI, specifically machine learning, works by feeding a system with certain amount of data, and then it classifies it according to certain features. And then as the machine gets feedback from the output from a lot of data inputs, an algorithm or a program is developed that makes it possible for the machine to learn by itself and be able to classify the newly inputted data by itself. Now, you probably are familiar with how this is currently being used, for example, by Facebook or Google Photos, to determine if someone in a picture is a certain person based on past tagged photos of that person. So it's very, very similar to that. And in urology, the input could be anything such as CT scan films, data from a patient's clinical history, or cystoscopic images, anything that could be converted to digital data. And then the output could be, for example, the machine learning to determine whether a lesion is cancerous or the likelihood that a patient would need hospital admission given his clinical history. And with this, the possibilities are now endless and the applications are really exciting. And what's more exciting is that it's actually already being used already in certain centers all around the world. For example, researchers from Stanford University have developed a deep learning algorithm for cystoscopy that could improve the detection of bladder cancer. You can see in the picture annotated boxes around the lesions, giving details about the tumors detected with cystoscopy. And gastroenterologists are also already using AI for colonoscopy clinically already. And it's very exciting how this is already benefiting patients. And at the rate these innovations are going, it is probably not too far in the future when performing a diagnostic flexible cystoscopy could be as simple as, say, inserting a Foley catheter, and then AI will be the one to do the diagnosing. And now, what's next? How about AI-controlled surgical robots that could, say, perform prostatectomies by themselves? Now, the possibilities are really, really endless and probably not too far off. I mean, we already have self-driving cars, which a decade ago, we wouldn't have imagined to happen in the near future back then. And as we have discussed all these new technology, we have really just scratched the surface of everything that's currently going on in neurological innovations. And as exciting as these all are, and whatever comes next, we should always be reminded that the ultimate purpose of these advancements is to benefit our patients. And as one of my mentors in residency training would always remind us back then, at the end of the day, our goal is to always, always give our patients the best possible urological care that they deserve. Thank you so much for your attention, and good afternoon, everyone.